Hi, everyone. Welcome in. We're going to give it just a few minutes to get all of our amazing attendees in and sound on. Welcome, welcome. All right. For the sake of time, I am going to go ahead and get us started. Hello, everybody. My name is Kayla Fulginetti. I'm the Senior Director at Elephants&Tea, and we are so excited to be bringing session number 6 of AYAO Power. A huge thank you, as always, to the AYA Oncology Education Working Group for partnering with Elephants&Tea and bringing this amazing curriculum to all of our participants and to kind of the AYA community and beyond. I am going to be just running through some very quick logistics so that we can get to the content, as I have a feeling this is a very hot topic right now and people are really interested in this. So we are very grateful and thankful to Dr. Jennifer Mack for being here with us. Just a few logistics from our end. As always, these sessions are being recorded. They will be available on the AYAO Power website. That is just a hub of information from all of our past sessions, all of the recordings, all of the landmark articles that our amazing experts have provided to us, as well as some lightning lessons, which are those quick and short condensed 2 to 4 minute videos that really get, again, to that, like, what is it that you really need to know from these larger conversations? So please make sure you're checking out the website. As always, if you have questions throughout the presentation, please drop those in the Q&A. We will be facilitating and moderating that at the end of the presentation. And then a very quick update about scheduling. Next month was going to be Dr. Susan Parsons. We are actually postponing March's session, and that will be rescheduled, but still continue to look forward to Dr. David Fryer is presenting in April, and Dr. John Salzman will be presenting in May. So we still have wonderful topics coming up to kind of round out the rest of Power. So with that, I will pass it off to my friend, Dr. Mike Roth, to introduce our amazing speaker today.
Thank you, Kayla, so much. This is such a special talk and topic today, and we're really privileged to welcome Dr. Mack. So very briefly, just to give a short introduction, Dr. Mack's Associate Chief of the Division of Population Sciences at Harvard Medical School. She's an attending physician at Dana-Farber and Boston Children's, which is also where she completed her training in pediatrics, pediatric hematology oncology, as well as palliative care. She's an international expert on communication surrounding prognosis, treatment decision-making, and transition to palliative care for children, adolescents, and young adults with cancer. She has many high-impact publications, but through many of these publications in highly regarded journals such as JAMA Oncology, JCO, and JNCI, Dr. Mack has truly brought much-needed attention to the needs of AYAs throughout the cancer care continuum. Today, she will share her insights on AYA's priorities for care while living with advanced cancer. Please join me in welcoming Dr. Mack to AYAO Power. Yeah, thank you so much.
Thank you so much, Mike. Apologies to the audience for my voice. I'm just dealing with a little laryngitis, so I hope people can hear me okay, and please bear with me. But thank you so much for that wonderful introduction, and I'm just so delighted to be here today. And this work is very near and dear to my heart, because this work focuses on what's most important to patients while they're living with advanced disease. So you may know already that actually close to 90,000 adolescents and young adults now are diagnosed with cancer in the United States each year. And in this age group, cancer is the leading disease-related cause of death. But their care needs at the end of life have been understudied. There's been existing work, including from my own group, that's found high rates of intensive measures at the end of life, like time in the hospital, ICU care, and chemotherapy. but the reasons for this are unclear, and it may be that some of this reflects what patients want. And so we set out to try to understand that better. There are sets of measures for older adults nearing the end of life that look at quality of care, but these haven't really been developed for adolescents and young adults, and they may have different priorities for care. For example, they may be most focused on um, their unmet life goals, their own social needs, and the needs of their loved ones, and the unlived life that they still want to live. So that's the reason that we set out to do this work, is to develop a patient-centered definition of high quality end of life care for adolescents and young adults. And so the work I'm going to present is based on interviews with AYAs, their family caregivers, and their clinicians. We used their words to develop a patient and family-centered definition of high-quality care. But then we conducted a Delphi process to identify the most important domains. And then today we'll just talk about these findings. Excuse me for needing a little tea. So in our interviews, we identified 7 main domains that were important to patients, and I'll go through those today. First is attention to comfort and physical symptoms. Second is attention to quality of life. Third is psychosocial and spiritual support. Fourth is communication and decision making. Fifth is independence. Sixth is relationships with clinicians. And finally, medical care and treatment. And so what I've done here is provided some of our patients' own words about what they wanted in each of these areas. So when it came to attention to comfort and physical symptoms, patients said things like that they want to be comfortable most of all, feeling the best they can in every capacity. And they also said something that I wasn't expecting, which is, that they wanted to be aware as much as possible. So, for example, one patient said, I don't want to be in a state that I can't take care of myself or make decisions. My biggest fear is my mind going. And a bereaved mother similarly said, whatever would help her with the pain side of things, while balancing that with not being out of it the whole time. And so, as we developed these quality domains, these were the attributes that were recommended by patients: feeling as good as possible physically, having as little pain as possible, but also being mentally aware and having the care team respect each patient's preferred balance of pain control and awareness. The second domain was around attention to quality of life, and there were a number of different areas here. The first one was around life goals and meaning. Excuse me. And so one patient said here, this was a young man in his 30s, and he said, I've at least had the luxury of, getting married, having kids, starting a family. I'm sure there's people that are on the cusp of doing that can't, which is pretty devastating. Another patient said um, uh, that he wanted to have had an impact on the world. He said, this is going to sound a little strange, but leaving something behind. Other patients were very focused on personal relationships as an important part of quality of life. One young woman said, I think just spending as much time with the people I love as possible, and hopefully being able to enjoy that time with them and have a peaceful goodbye and closure for some people around me. Another patient in the same age range said that she wanted What can I do to make sure that family is taken care of? There are some family members where the thing that would best support them for the future would just be conversations, emotional support. I feel like things need to be said that could really make them in a better position to grow and kind of get over some stuff. And I think, these quotes for me are so powerful because they remind me that many patients are not just thinking that they want these relationships for themselves, but they want their loved ones to be okay and to live on and have their own good lives. Here's another one from a provider. Once she knew that chemotherapy was not going to really help her, it was all about being around for her kids for as long as she possibly could. And another provider said he wanted his family to be as at peace as they could be with him dying. He didn't want to die without them having heard from him that he doesn't want them to worry. Other young people also talked about normalcy, being as normal as possible. One patient said, I can still live a normal life if I look forward into it. I can go back to work, I can go back to school and finish another degree. And a bereaved mother said, we lived as normal of a life as possible. That was his priority. That's what made him happy. Sorry again for my voice. But these were the attributes we thought about when we thought about attention to quality of life. So patients wanted to have the best possible quality of life. They wanted the care team to understand what quality of life means for them and support it. They wanted the care team to understand who the important people in their lives are and have the opportunity to talk about those loved ones' needs. And then they wanted to have as normal a life as possible whenever possible. Next, the next attribute was around psychosocial and spiritual support. And one bereaved parent said, part of someone's care is helping them and their family figure out whatever strategy for themselves works in terms of just making sense of all this. Some people may presume it's going to be a faith-based thing, but it wasn't for us. None of us are conventionally religious. And so here, thinking about finding meaning in life is not necessarily conventionally religious, but is an important part of that spiritual support. And then in terms of psychosocial support, again, a patient was thinking about her family. You need to open up that communication and make sure that everyone's being heard, arming people with the ability to hear and listen. That's it. I think that would be very beneficial. A nurse practitioner mentioned addressing fears of the unknown. And then a palliative care physician said, allowing the patient not to be so anxious, still to be able to laugh and joke sometimes. And so these were our attributes, being offered support by a chaplain or spiritual provider, being offered support of a psychosocial provider, getting help working through feelings, good and bad, making sure loved ones receive help working through their feelings, and having as little anxiety as possible. And again, many patients were thinking about their own needs, but in tandem, their family needs. And that was an important lesson to me as a provider. And so then the next attribute was around communication and decision making. And one of the areas that was emphasized was around prognosis. This patient said, what's a likely scenario for me? How much more time do I have and how well am I doing? One provider said, We should talk with them earlier on about what's most important. If they want to know if they're in trouble, letting them know so that we can understand what's most important about it, to give the time to do the things they need to do. And another patient talked about decision making. I don't want to be excluded from the options. What are the different options for me? I don't want the decisions to be made for me without me. And so in this area, these were the attributes that we recommended. Helping patients to know the range of what could happen because of the illness, and having the care team respect wishes for information about what could happen and how long the patient might have. And again, patients might want that information or they might not want it. But the key is, do we hear that and respect it? Patients also wanted help and support from the care team when making decisions, and to be as involved as they want in decisions about care. The next attribute that we looked at was independence in medical care. And this was for the wife of a patient. And she said, she still really wanted independence in the last couple of days. And, she talked about the patient needed help going to the bathroom, but didn't want it. And this wife said, you can't really die alone if you have people in your life that love you. A palliative care physician said, relationships with family are complex at that time in your life. They're trying to find their independence, and yet cancer always puts them in a state of dependence on their parents. And so in this area, the things that patients were asking for were things like being as independent as possible with daily care. They might not be able to be completely independent, but to give them the tools to have as much as they can. And then patients also wanted to have conversations about the kind of help they would need, including the impact on loved ones, because many were worried about burdening the people in their lives. The next area, I'll take a drink of water, sorry. The next area was around relationships with clinicians. And this came through as a very important attribute to most patients, that they wanted to have this therapeutic bond with their clinicians, their nurses, their doctors, their psychologists. One bereaved caregiver said they talked with him about personal things. They took the time to get to know him, and that was so important to her son. Another provider talked about hospice was coming in, but I knew the most about her. I knew what her goals were. And then a bereaved mother said, that lots of different people are coming in and out, in and out. The fact that you don't end up with one person is incredibly difficult. And so in this area, I abbreviated the quotes a little bit, but these are the kinds of things we heard. They wanted to have a good relationship with the care team, feel like they listen to them, feel like they understand what's important, what the patient wants to experience and achieve in life, to be seen as a whole person, to be cared for in a compassionate way, and having as much continuity as possible, receiving care from main care team members who know them. And then we also looked at issues around medical care and treatment. And so one of the areas many patients talked about was cancer therapy. And so, one patient said, at some point you hit the threshold where you don't gain anything. You might be on chemotherapy at the end of your life, but what's it really getting you? There are diminished returns. And this patient thoughtfully pointed out, some people don't care that your returns are diminished. Some people do. Another patient said, if it's not working, there's no point in making yourself more sick and feeling more pain. But then another patient said, I would be willing to compromise my quality of life for a certain amount of time to take a chance. I would try pretty much anything to be here longer. And a bereaved mother also said, the doctor very much believed there were no options, but we were trying to turn over any stone. And so, just to sum these very different perspectives up, this one provider said it's all about what makes sense for that person. There's not really one path here. And we found very similar perspectives around life prolonging measures. One male patient said, I'd want to know what the benefit is of having all that extra if they know that you're dying anyways. And then another patient said, as aggressive as it needs to be, that's what I'm going to do. I take on a competitive fighter mentality. And then when it came to location of death, many patients raised this topic as well. One patient said, I want to stay at home as much as I can. Another one said, yeah, I want to be out of the hospital, but if I'm really sick, I guess I'll go there. And then a bereaved caregiver said, as we were driving home, the patient said to her mom, if I have to die, I'd like to go be at home, but I'll understand if I have to go to the hospital. And the mother then had to make the decision herself. This is going to have to be in the hospital because I can't do this. And so again, there's a lot of flexibility here. It's not that they have to be at home. It's that they want to be in a place that's right for them and that's right for their family. And so these were the recommended attributes that we saw. We recommended that patients understand the purpose of cancer treatment, including whether cure is possible, and then have the care team understand and respect what's important to the individual when it comes to cancer treatment and when it comes to being in the ICU or using other kinds of treatment to stay alive. Patients also wanted to have the care team understand and respect wishes for where they receive care, and then have a say in where they might die. If they chose to die at home, they also wanted to have the right supports in place for them and their family. So just to summarize this, these measures of care quality are really quite different from what we've seen for older adults, where the measures are really about, does the patient die at home? Do they spend time in the ICU? Do they get chemotherapy at the end of life? Here, patients are really wanting to have care that respects their personal preferences. There's not just one path. And so, just to reflect briefly, and then you can stop listening to me and we'll go to questions. But how do we support priorities in these areas? So these are the things that I remember now when I take care of patients. When it comes to comfort and physical symptoms, in addition to thinking about comfort, I also can ask them, what's the right balance between pain control and awareness for you? When it comes to quality of life, understanding what does quality of life mean to you? Who are the important people in your life? What does it mean to live a normal life? And how can we support the people you love? When it comes to psychosocial and spiritual support, offering support as a normal thing. It's normal to need to work through feelings, good and bad, and make sure we're listening and thinking about the needs of family members. Because many patients said to us, if my family's not okay, then I'm not okay. When it comes to communication and decision making, asking patients, would it be helpful to talk about what to expect if your illness progresses? Would you like to know about the range of possibilities of what could happen? And letting patients know that we want their input in decisions and that we're also going to support them. We're going to help them and make the decision together. When it comes to independence, making sure that family caregivers are prepared for home care needs to help patients not feel they're being a burden, and asking patients about their wishes around independence and whether there are areas where that's especially hard. For relationships with clinicians, this isn't really about understanding a single priority, but just developing a relationship that builds over time, understanding what's important to that patient to experience and achieve in life, being present with them, and maintaining continuity, especially during transitions like to the hospital or hospice. And then for medical care and treatment, understanding that care is not going to look the same for everyone. And the best we can do is understand what's important to those individual patients. So, in all areas, what we heard very strongly is that patients want their individuality respected and their personal preferences, that their needs and wishes may change, and that we need to work with young patients to understand their personal needs and what their family needs. Make sure they have their own time and space to make sure their voices are heard. But remember that there are often these close ties for family, so to ensure that the wider network is considered. I just want to thank my incredible team of people who helped think about these things, um, and the many patients and families who participated in this study. And I'll stop sharing now, so that we can have some questions. Thank you.
Wow, Jenny, that was phenomenal, and thank you for powering through, knowing you're a little under the weather, but there are so many pearls that you shared, and I think many of us have so many questions and comments and thoughts of how this impacts the care of our AYAs on a daily basis. There's a few questions in the Q&A, but I'd like to just start off by asking a question that comes up a lot with our medical oncologists, where perhaps they're more comfortable with caring for older adults with advanced cancer or near the end of life. And when they have a younger adult, it they find themselves facing more challenges and more discomfort of how to care for them. Any comments on sort of thoughts or recommendations for sort of how clinicians can approach that sort of difference in age and stage of life?
Yeah. Yeah, I mean, I think one of the sorry, one of the most important things we can do is ask them what they need. So, for example, the questions around prognosis, people may worry about talking with a young person about prognosis. Um, but that shouldn't be a reason to not offer that information. We can be aware that we're worried about that, but also offer it in a way that's sensitive. And, I think what I put on the slide is what I often do, which is say, would it be helpful to talk about this, to understand what might be ahead for you? And, I find, well, we did a previous study a few years ago looking at prognosis communication for adolescents and young adults. And we actually found that even among patients with poor prognosis, that patients who had open conversations about it were less distressed, were more hopeful, and had greater peace of mind. And, it seems counterintuitive, but I think sometimes the unknown is so hard, so stressful. And so, just giving them the opportunity to have these conversations is so important. And they may say no, they may say I'm not ready, and that's fine.
Yeah, that's so helpful. I want to get to some questions in the Q&A. I also want to invite folks to please consider turning your camera on, raise your hand, or come off mute. We really do want this to be a discussion, and make sure that we are addressing all of your questions and concerns. So one of the questions in the Q&A relates to sort of who should be providing this end-of-life care, and are end-of-life doulas becoming more recognized in the field of sort of providing end-of-life care, or is there still a focus on palliative care professionals? Or I would add to that layer, specifically in the community oncology setting of, who is providing end-of-life care for most of our AYAs?
Yeah, that's a great question. I think that the the landscape is definitely growing. And I think we don't have a lot of data about, professionals like doulas, but I think that's an area that would be great to learn more about. I think that, it often does take a team. There's often not one single person who's the right person. Um, but I think that, having a collaborative interdisciplinary team that might include oncologists, nurses, palliative care professionals, hospice professionals, chaplains, psychosocial providers, et cetera, can help to provide a network of support around patients. And, um, and then we have to think about what's right for each patient and, support the connections that are positive and meaningful to them. Yeah.
Yeah, that's really helpful. Again, anyone who wants to come off mute, please feel free to do so. Feel free to turn your camera on. Another question in the chat has to do with communicating as caregivers with young people who are asking, why is this happening to me, or what did I do to deserve this? Oftentimes there's a lot of stress on our caregivers of not knowing what the appropriate responses are. What have you learned in your practice and in your research about how to address those concerns?
Yeah. I think that that's not a question. Why is this happening? It's not a question that's specific to young people. I think it's the question, right? For a lot of people in life, why do difficult things happen? What does it mean? And I think that personally, I don't have the answers, and so the thing that I try to do is be comfortable with the questions, and have conversations about those questions. But I don't feel pressured to answer them or have the answers because I don't have the answers. But I think the more that we can acknowledge these sources of distress and help patients think about what does provide meaning, what does help them integrate what's happening, what it means to them, that's the best thing we can do. And so I try to encourage caregivers as much as they can to just explore, to be with those questions and to say, well, have you thought about this? What have you thought about? What does it mean to you? And to try to keep an open conversation, because I learned so much from my patients,
Yeah.
in having those conversations, and it's hard as a caregiver to go in that territory. I think sometimes it's almost easier as a provider. But if they can tolerate it, they can get to some really important conversations.
Yeah, that's incredibly helpful. We've got some sort of affirmation in the chat as well of that response. I'm also realizing that I made a webinar faux pas here. I'm telling everyone to come off mute and turn their cameras on, but I don't think you could see each other. So again, perhaps in the future, we'll change the format. Please do put questions in the Q&A and or the chat box. Another question that came up is, first, just thanking you for the great talk and the great discussion. What tips can you provide on providing continuity of care and psychosocial support when an AYA is transitioned to hospice? This might be related to check-ins with phone calls or video visits. How should providers continue the care because they've developed such strong relationships?
Yeah. And that when we had that nice quote from that one, palliative care nurse practitioner who said that that he felt that he had to stay involved, right? He was the source of continuity. And I think that's often the case for us, that we may have worked with patients for years, and it doesn't feel right to say, okay, well, now here you are at this critical time,
Yeah.
and I'm going to let go. And so, I think there are different ways of doing this, and it depends on what the family wants and the nature of your relationship. When I can, I sometimes will visit people at home, and I find that I learn so much, by seeing them in that different environment. I kinda wish I could do it earlier in care too, to be honest, but, we all are so busy, it's just so hard to do, but when I am able to do that, it's a nice thing, it means a lot to me and the family. I do think this new age of Zoom is a great thing too, and I've started doing more video visits if I can't make it out there, and then of course phone calls. And um, I find that it doesn't always need to be a long phone call either, right? I remember there was one family I used to call from the grocery store, and they understood, they just wanted those few minutes of checking in, knowing that I was thinking about them, and so you have to find a way that it works, for you, that that it works okay for your life. But I think if you're able to do that, the benefit goes both ways. It's not just good for the patient and family, it's good for us. And that's not the only reason to do it, but it's a nice thing.
Yeah, I mean, that's so impactful. And I really appreciate also just thinking about how patients impact, their caregivers and their providers. I mean, this field is more of a lifestyle than a profession, and in that, we're all in it to support our patients and we care so deeply about them. So I appreciate also just thinking about the providers, own wellness and health as well, and
Yeah.
making sure that all can be supported in this process. The questions are really sort of coming in pretty quickly now, so I want to make sure we use our time to address as many as possible. So Daniel and I had the same sort of comment and question. So, first he noted this is an amazing presentation, which so many have noted already. And then he has a question about sort of central tools or central resources. I always worry that we don't have a lot of broad expert sort of knowledge and support for AYAs across our cancer care settings. And he wanted to know, are there certain tools or resources that are helpful specifically for AYAs at the end of life? It took me about 30 seconds to figure out VMC was voicing my choices. Have they found this helpful? What have you found in your practice and your research?
Yeah. I'm glad you brought up voicing my choices. I was going to mention that too. That's a wonderful tool that Lori Weiner developed, who's at NCI, and is kind of a little bit like a five wishes or an advance directive type of document, but it's tailored to AYAs. So it walks them through, thinking about what might be important to them in their lives and along different lines. So I think those tools can be very, very helpful. I, I, I tend to um, be a little bit less, to use tools a little bit less, and to just, I feel like being ourselves, and being open to these conversations is really the best thing. And so I think that you have to be comfortable with it, and I understand it takes time sometimes, and you may not always feel comfortable. And I've been doing this a long time. I don't always get it right. I think it's not always a beautiful conversation. Sometimes it's stressful. Sometimes people are upset. But I think the more that we can just be willing to, you know, learn who our patients are, what's important to them, and then, talk that through with them about how we can enable that, as their disease advances, I think is one of the best tools.
Yeah, that's really, really helpful and appreciated. I see Maureen put in the chat that she had a similar scenario in terms of follow-up for a recent patient who was transitioned to palliative care, and she and her patient agreed to have weekly check-ins and phone calls, and it sounds like that was comforting, perhaps both for the patient and for the provider. So,
Yeah.
Maureen, thanks for that helpful comment. A few more questions, and I'm sure we will run out of time, which I kind of anticipated for this talk. You mentioned in your presentation a little bit, and there were a couple quotes about legacy, about wanting to make an impact on the world. Can you talk a little bit more about how AYA sort of expressed the importance of legacy, and have they lived a long enough and full enough life to make a difference, whether it's on others or making a broader difference on a community?
Yeah. I think this excuse me, this question, this issue of legacy comes up a lot, both in clinical care and in these interviews. And I think a lot of it is just wanting to be remembered, and to have had a positive impact on others, and to not have had a lasting negative impact on others, worrying about their family, being able to go on in life. I remember one of my teenage patients, one time asked to talk to me alone, without her parents. She was probably 15, and she said, "Are my mom and dad going to be okay?" That was the central question for her. Um, and so I think, legacy can look like a lot of different things. Her asking that gave me a chance to say, not, that of course it was going to be hard, but they also have had the joy of knowing her for these 15 years, and I have too, right? So oftentimes as a provider, I try to affirm that there are things I'll always remember, that they've said to me, or that they've done, or just who they are. And I think that's a nice, small intervention that we can make, is to reinforce that, there that each of these individuals is, unique and special, and we carry that with us. Yeah, I don't know if that answered the question, but
Yeah, no, it's great. I have to admit, I've been adding to my toolkit as I see the heart sort of fly by. I didn't know you could do that in the webinar setting, but
that's
I,
okay.
I've yeah, I think many of us have felt like our toolkits have expanded greatly today. Just knowing some additional things to say, ways to connect. Um, a couple more questions, if that's okay, and you're still up for it, Jenny. So I really appreciate the multidisciplinary approach that's needed in all areas of oncology, especially for patients with advanced cancer. And Ellie writes about nursing's role in caring for patients at end of life, and importantly highlights that many clinicians feel like it's a failure if patients don't have the outcomes that they were hoping for at the beginning or during treatment. And what can nurses and social workers and other folks do to try to make sure that our AYAs get all the care that they deserve, and also that some of the barriers that currently exist to getting younger patients adequate, appropriate, optimal end-of-life care really do move forward?
Yeah. Yeah, I think that, for many reasons, it's very hard for us as providers when patients don't do well. And and I think, for medical oncologists, where the young patients are not as common, I think it can be particularly hard. to see younger patients not do well, and for nurses and social workers and psychologists who mostly take care of adults. Um, I think that it's important to separate our own feelings of sadness and failure from the patient's feelings, and not um, let that impact how we take care of them. You know, that's where we go in the nurse's office and talk to our friends, right? um, and and because I think many patients feel some of this themselves, they wonder if they failed us. And so I think as we share, if we're sharing some of those feelings, of course, I support openness about a lot of things, and I support openness about how hard it is as providers, or how sad we are when our patients don't do well. Um, but I might caution against letting those feelings of failure come to the patient, because, again, I think many of them feel that too. Um, Years ago, I wrote about the day one talk, which is the talk we have at the time of diagnosis. And one of the things we suggest saying to children and adolescents and families at diagnosis is addressing causation, that it's not their fault that this happened. And I actually do something very similar at relapse or at the end of life, where I, will often say, you did everything we asked you to. And it's not your fault that this happened. You deserve all the good things. Um, to try to help them understand that this is, just to try to recognize that they have those feelings too. Um, yeah,
Yeah, I'll have to admit it's heartbreaking to know that some, if not many, of our patients worry or feel like they've let their providers down or haven't done
exactly,
everything that they needed to do or could have done to sort
exactly.
of reach the outcomes. And I think for many of us, it's really just about trying to make sure our patients know that they have done everything and gone beyond, what we've hoped for, and there are just some things that are unfair, and we're here to support them.
Yeah,
A couple more questions, and then I always give folks back time to their days and their lives, so I will not sort of avoid that routine, although I do want to maximize our time with Dr. Mack. So the next question has to do with support for caregivers, for siblings. I'll also add for children, thinking about young children of our AYAs, and that's an area that often is unrecognized, and often there's not a lot of support. Any advice or guidance, central resources, or ways we can better support our caregivers and children of AYAs?
yeah, yeah. I think it's a hugely important area. There are some resources, and I'll have to find them, but maybe I could follow up with this, with you, Mike, and you could disseminate them, for, you know, um, children of parents who have cancer. Um, and I think very similar issues hold for siblings. And I think these are highly impacted groups, of course, where we don't really have as much natural support. We in pediatrics, we have support for the parents. In the adult world, it's most focused on the patients. And um, but neither group is really thinking as much, I think, about this wider network of people who are impacted. Of course, I mean, many people do this well. I don't mean that, but I just think that these are groups that need probably more than what we're giving. Um, I see someone mentioned ACS has good resources for parents. That's very true. Um, and I was going to mention that concerns about siblings and children often impacts choices about location of death. Um,
Yeah.
and so dealing with some of those concerns can also help patients to have more options or feel that they have more options about where they die. So it really is central to a lot of aspects of medical care.
Yeah, that's so helpful. I see a few comments in the chat supporting, some of the resources or providing some resources that may be available for caregivers and family members. There's a comment in the Q&A at UCSF. There's the Honor Project for
Yeah, yeah,
providers to grieve the patients as
yeah,
well.
yeah,
So I want to end on maybe a little bit more of a personal note, and I hope, Jenny, that's okay. Carrie placed the comment in the chat box about how difficult this can be for providers as well. And Jenny, you've been doing this for a long time, and you've done such great work, clinically impacting the lives of so many patients. And you've really broadened the reach of your work by all of the wonderful research that you've put out there. I'd love for folks to hear a little bit about how do you deal with this? You're in it all the time. I always worry about our bedside nurses, about our social workers, who you're always in that high emotional, roller coaster. Any tips or tools about what's worked for you and allows you to sort of continue to do this work and do it so passionately and also allows you to smile and be happy and hopefully enjoy life inside and outside of work?
yeah. I mean, I don't know that I have an answer that's, that is kind of the one thing someone should do, but I guess I find that I love the work in a lot of ways, and it adds to my life. It adds, meaning to my life, and I've never been somebody who found that kind of setting boundaries or getting distance really helped me. I found that that just made things more complicated. And so it's not that we don't all need to do that. Sometimes we all need to unplug and go on vacation and not have the pager and, all of that. But I think that that for me, being able to um, be present, be involved, be part of these experiences with families, have these conversations with them about what it means to them, and that's part of what is sustaining, as opposed to being something that takes away from my ability to keep doing it. But it helps, you gotta have other stuff in your life that you love too. It
Yeah, I
Yeah.
mean, that's really impactful, also really inspiring. I'll share with the group, we had a recent AYA retreat at MD Anderson, and we did one of the Brene Brown workshops, really focusing on, what do we need in our lives and from work. And the common theme was just finding meaning and having that meaning at work and what you do. You spend so much time. And because the work was so meaningful and impactful, that really has driven many of us on this call and who do this professionally, and it extends beyond the walls of sort of work, to really just kind of drive us to keep going. Uh, on that note, Jenny, I personally want to just thank you. This has been such an important talk. It has reached many on this call. It will reach many beyond this call because all of this lives within our AYAO Power curriculum. I'm going to pass it on to Kayla, and I apologize, Kayla, for making the error that this webinar had the ability for folks to unmute and we can see everyone's lovely faces. But Jenny, thank you so much. This has truly been inspiring and incredibly impressive and important.
Oh, thank you so much for having me. I'm just sorry everyone had to listen to my voice. I do have a normal voice, so another time maybe you'll hear it.
Oh, wow. I feel like that's an offer to come back that I just heard. So thank you so much again. I will reiterate from all of the power team, Jenny, thank you for this. I feel like this was such a wealthy conversation and topic, and the questions were just beautiful. So thank you again for being here. For everybody that's on, just a reminder again that next month's session for March, will be postponed, but we still have 2 more coming up. So stay tuned. If you are not subscribed already to our emails, we will have information about the final dates for those, as well as Dr. Susan Parsons' rescheduled session in the future. I also wanted to express a thank you to AZI, as they are supporters of AYO Power, and we are so grateful to them for their support. Lisa has dropped a survey in the chat. So we really do take your feedback, and I will plug that we are already starting to think about what AYO Power 2.0 is going to look like. So your thoughts and feedback on that would be wonderful and absolutely taken into account. So thank you again so much, everybody, for being here. We will see you in April for our next session. Have a wonderful rest of your day, everybody.
Thank you, everyone. Thanks, Jenny. I know people are leaving. Jenny, that was phenomenal. And again, thanks for doing this while you're under the weather. But I mean, your presentation